as Madam told, for the last 2 years, since Josar became the president, I think this program is going without any gap. Like every Thursday at this particular time, there is a PG clinical discussion which is happening. So this is something very unique for IAP Kerala. And a few days back, actually, I made a discussion with the team of PG Club along with Josa. And we are planning to continue the PG Club activities next year also with some new additions. Like we are planning for some short case discussions also, and a few guest lectures by inviting faculty from outside our state, as well as, if possible, a few quiz programs and debates and like that. So this week actually the program is hosted by IAP Kottayam, and I should congratulate the Kottayam team headed by Darli Madam, as well as our coordinator Dr. Thomas, for taking all the pain to organize this program, and also my dear friend Shahanas being the discussant. I am so happy because we are together since the last 30 years, and I always like to listen from him and to learn from him. So without any delay, I hand over the mic to Dr. Thomas for continuing the program. Thank you.
Jose sir.
Continue. Scientific continue. Scientific continue. Scientific.
Okay. Okay. Requesting Cyril sir. Okay. Requesting Cyril sir, professor and Unit 2 chief, and who is a mentor, to introduce the speaker, presenter, and the case.
Respected teachers, colleagues, and PGs, we are very happy to have Dr. Shahraz, who is Associate Professor of Pediatric Neurology, Department of Pediatric Neurology, SAT Trivandrum, for this PG discussion. Dr. Varun JR3 will be presenting a case, a child of 1 year and 9 months with a history of loss of attained milestone. We are sure that this class will be very useful for both the PGs as well as for the faculty and teachers. All the best.
Thank you, sir. Namaste.
Sir, Shana sir, we can start.
Okay. Okay, start. Varun, you can start. Thomas, in addition to Varun, who are the others present? Only is Venkat. Then
Venkat, where are all? Varun?
August joins here one there.
August.
Others.
Divya, Divya, Tandoor, Divya.
Gobi,
Gobi.
Thomas, students say, അവരുടെ പേര് വെച്ചിട്ട് ഒന്ന് കേറാൻ പറ. Then it will be easy for Shahanas to call them and ask.
Okay.
അപ്പൊ ഇപ്പൊ 3 പേരുണ്ടല്ലേ? വെങ്കിട് ഉണ്ട്, ആകാശ് എന്ന് പറഞ്ഞൊരു PG ജോയിൻ ചെയ്യും. ആകർഷ്. ഓക്കെ. പിന്നെ
ഗോപി, ദിവ്യ.
ദിവ്യ. 4 പേരാണ് ഫൈനൽ ഇയേഴ്സ് അല്ലേ? ഫൈനൽ ഇയേഴ്സ്. ഓക്കെ.
പക്ഷെ ഒരു പ്രശ്നമുണ്ട്, പല ക്ലാസ്സിലും എന്നെ തെറ്റി വിളിക്കാണ്. ദിവ്യ ഡി എന്ന് മറ്റേ
ദിവ്യ ഡി ആണ് സാർ. മ്യൂട്ട് ചെയ്യാം.
Welcome, Anandarshan sir. വരുൺ ഇനി ഡിലേ ഉണ്ടോ എന്താ?
ഇല്ല.
വരുൺ സ്റ്റാർട്ട് ചെയ്തോ? വരുൺ
സ്റ്റാർട്ട്.
സ്റ്റാർട്ട് ഞാൻ ഉണ്ട്. വരുൺ സ്റ്റാർട്ട് ചെയ്തോ? ഞാൻ പിന്നെ വേറെ ആരും കേറാൻ ഉണ്ടോന്ന് വിചാരിച്ചിട്ട് അങ്ങനെ വെയിറ്റ്
ഇല്ല സാറേ.
ഓക്കെ സാർ.
Good evening to respected IAP members, my teachers and my colleagues. Today I am going to present the case of a 1 year, 9-month-old female child who presented from Muvantura with a native place at Tengashi, Tamil Nadu. Informal is mother, information is reliable. The child presented with the complaints of a delay in attaining milestones in the early infancy and loss of already attained milestones for the past 6 months. Since baby is having complaints since early infancy, I would like to start from a antenatal history. Second child of a 3rd-degree consanguineous marriage. The child is having an elder sibling who was born term via normal vaginal delivery quite soon after birth weight of 2.5 kg, a male child, now 5 years, development in normal child, no history of any abortion, mother married at 19 years, conceived the second pregnancy at 23 years, spontaneous conception, urine pregnancy test positive after 6 weeks of amenorrhea, antenatal care at Sabine Hospital till 4 months of age, 4 months of gestation, followed afterwards at the Tamil Nadu. No history of any hyperemesis gravidarum, fever with rash, neck swelling, hypothyroidism, drug intake, radiation exposure, urinary tract infection. 18 scan was done, which was normal. Mother was informed to have some uterine anomaly in that 18 scanner. Folic acid taken. Occurring felt at the 5th month, no history of any gestation, diabetes mellitus, gestational hypertension, bleeding per vagina, urinary tract infection. Anomaly scan was done and was informed to be normal. Iron and calcium taken. ED2 doses were taken. Mother has noticed a decreased fetal movement as compared to the first child in this pregnancy. No history bleeding per vagina, leaking per vagina, urinary tract infection, diarrhea, iron and calcium is taken. The mother had history of a preterm labor pain at 30 weeks and presented to local hospital in labor and delivered a very preterm, at 30 weeks baby via preterm vaginal delivery, and the baby cried soon after birth with a birth weight of 1.37 kg. The baby was
Varun, can I interrupt in between to ask a question? Because I may forget later on. I usually tend to forget after 5 minutes everything. The thing is, you said regarding the previous slide, decreased fetal movements felt by the mother. What is its relevance?
The fetal movement can be decreased in oligohydramnios, in fetal SMA, congenital myopathy, congenital myotonia dystrophy.
So that means when you, this decreased fetal movement, in which type of case presentation this is very important, this point? Is it in CP, neurodegeneration, or any other type of case?
Neuromuscular diseases.
Yes, that is called a flow in the discussion of floppy baby. And the floppy baby, this becomes important. Then what you should do is, this case it may not be that much important, but what you should do is you should ask what was the time of appearance of the fetal movements, and was there a delay in the time of appearance, and after that, after appearing, it was generally decreased throughout the pregnancy, or was it decreased only for 1 day or so? What could be the relevance of that question? Because if it is reduced for 1 day only, it may be due to a temporary dysfunction of the brain. For example, a cerebral ischemia due to APH, small APH, etc., leading to decreased fetal movement temporarily, but after that it recurs. For example, certain hemiplegic CP patients' mothers, they may complain that during the 5th to 6 months of pregnancy, temporarily for 1 day or so, they had some decreased fetal movements, but after that it again normalized. So that means central insult has occurred. But like you said, if it is reduced very much when compared to the first child, and sometimes reduced or not at all present, very quiet, it may indicate a what disorder? Peripheral floppy, LMN floppy. In that peripheral floppy, in such a situation comes where the reduced fetal movements are very much reduced. I will have 2 questions. One is, what are the possibilities in such a situation? Differential diagnosis. Very much reduction of fetal movements. One is fetal origin SMA. Very good. Fetal origin SMA. Then second,
congenital myotonia dystrophy.
Congenital myopathy. Okay, if you must first say congenital myopathy because it is more common. And myopathy, then congenital muscular dystrophy, congenital myotonic dystrophy. So you see, these three are muscle localization things of floppy belly. So in the muscle localization things, these three have severe forms as well as less milder forms. So the severe forms of this congenital myopathy, congenital muscular dystrophy, or congenital myotonic dystrophy, or sometimes even congenital myasthenic syndrome. So all these can present with the decreased fetal movements in addition to fetal origin SMA. So these are the 5 differential diagnoses we should tell. So let me ask Agarsh, if he's present. So the thing is, otherwise you answer, no problem. The thing is, what is the, sequelae of this thing? Reduced fetal movements in utero. What happens when the child is born? Is there anything you notice grossly? What is the consequence of reduced fetal movements in utero?
Contractures can occur.
What is that condition called as?
Arthrogryposis.
Agrogryposis. Okay. Divya is present? No. Then Gobi is there? Okay. Then you can tell. That is, what is this definition of arthrogryposis in one sentence?
Multiple contracted joint.
No, a congenital contracture of joints is called arthrogryposis. Congenital contracture of joints. ജനിക്കുമ്പോൾ തന്നെ contracture ആയിട്ട് വരുന്നതിനാണ് arthrogryposis. അതിന്റെ ഒരു peculiarity, joint development കൂടെ affected ആയിരിക്കും. Okay, നമ്മൾ contracture പറഞ്ഞുകൊണ്ടൊരു question, ഒരു side question. What is the difference between dynamic contracture and fixed contracture? This is not in neurodegeneration, it is in CP. But it's a different mechanism difference. You need not tell the test to differentiate, just the mechanism difference.
In fixed contracture, when we try to
in dynamic contracture, what is the problem? The pathophysiology.
It is a spasticity eventually.
It is the spasticity of the muscle that causes the problem. The muscle spindle is very tight and muscle is spastic. So you can relieve it to some extent by giving drugs or during sleep, or you can push it down. You can stretch the tendon a little more so that the Golgi tendon organs send an impulse which relaxes the muscle. So that is that aspect is there. But in fixed contracture, what happens? What is the pathophysiology mechanism? In fixed contracture, there is collagen deposition in and around the joints and also in the tendon, so that there is a fixed default. It cannot be quickly corrected by the dynamic, that is pushing of the feet. It cannot correct. So but still this fixed contracture can be managed with physiotherapy and other physiotherapy techniques, including AF, orthos, etc. And if it does not respond even after 6 years, we may consider Z-plasty or other surgical procedure. Usually surgery is not considered. Initially we try physiotherapy maximum. Okay. You can continue. Okay.
The baby was born as a very preterm baby at 30 weeks via preterm vaginal delivery, and the baby was admitted to NICU in view of prematurity and respiratory distress. The baby was on O2 support via nasal pumps initially and was shifted to Government Medical College Tirunelveli at 4 hours of life, and was then on mechanical ventilator support in view of respiratory distress, weaned from ventilator support on postnatal day 7. O2 support was continued till postnatal day 30 in view of respiratory distress. Enteral feeds start on postnatal day 7 with the express breast milk via orogastric tube, and parallel feeds started on postnatal day 30. Newspaper feed intolerance or
what was the weight of the baby at the time of birth?
1.37 kg at the time of birth.
So what is its relevance? This weight, what is the relevance of that weight as far as further prognosis is concerned?
It's a very low birth weight baby.
So it is likely to develop? If it is Cerebral palsy. Yes, there is a 23 times risk of developing cerebral palsy with very low birth weight. But regarding prematurity with hypoxia, what is the type of CP which develops with the prematurity? That is only not weight is more than 1.5. That is diplegic CP. Okay. Okay. In that context, has anybody of your friends joined Agarsh, Gobi, or Divya?
Vengi has joined.
Who?
Vengi. Yeah,
Vengi is there. So I will just, this is for Vengi only. Vengi, what is the difference between, you tell me the difference between triplegic CP, tetraplegic CP, and quadriplegic CP.
So in quadriplegic CP, all the 4 limbs will be affected along with the neck muscles, spinal muscles, and will be affected in quadriplegic CP.
Okay. Then what is tetraplegic? That also 4 limbs are affected. Tetraplegic.
Tetraplegic CP, like both the upper limbs and lower limbs are involved. Upper limbs are more involved than the lower limbs.
Okay, what about triplegic? I will answer your, I will correct your mistakes after this. But what is triplegic CP then? What is the mechanism of triplegic CP?
In triplegic CP, either the both lower limbs with the one upper limb will be.
Or that is lower limbs with either the lower limbs with one upper limb or
both upper limb with the one.
Okay, that is so. There are actually, I am not pointing out the mistake. I am just trying to explain only. The thing is, diplegic CP. I will tell one by one. This you remember, right? Because other people are not there, you take it. This diplegic CP means there is lower limb involvement. But in MBBS, we tend to teach them that it is lower limb only, upper limb is spared. But actually, upper limbs are subtly affected. As a PG, when you are answering diplegic CP, if the examiner asks whether the upper limbs are involved or not, then you should say upper limbs are subtly involved. What is this subtle involvement? When the in the later part, after the child recovers after 2 years or 3 years, if the child is subjected to fine motor activities, there will be slight discrepancy between a normal child and this child. That is diplegic CP. Okay, now let us take the triplegic CP. How it develops? Triplegic CP develops because there is an asymmetric PVL. You know that it is diplegic CP is due to periventricular leukomalacia. Why the periventricular leukomalacia affects the legs? The other one, why the periventricular leukomalacia affects the lower limb alone?
The lower limbs, anterior cerebral artery.
No. Don't tell. Never tell that. That you leave. We will forget that you told that. The thing is, the lower limb fibers in the corona radiata, while they see it is in the corona radiata, all these things are happening. The lower limbs fibers, when they are traversing the corona radiata, are most medial. That if possible, by God's grace, I will send you a drawn picture later through Thomas. I will, which I usually draw for my PGs here. That is, or we will take in the next class later on, CP class. I will explain to you every mechanism. But the thing is, this diplegic CP, the lower limb fibers, when they are descending in the corona radiata, automatically become, because they are arising from the paracentral lobule, they automatically are aligned medially. So upper limb fibers are, upper limb area is represented more laterally. So the upper limb fibers come and oppose to the lower limb fibers. Suppose to one side, there is one asymmetric PVL with one side a little more affected. What happens is that the upper limb fibers in that side are affected, and so the opposite upper limb is affected. That is triplegic CP. You understand? So triplegic CP means both the lower limbs as in diplegic CP plus one upper limb. I hope you understand. Varun, Vengu,
Yes.
you understand? Okay. Now suppose there is this preterm child has more hypoxia, and we are not able to provide the proper care, etc. And there is bilateral symmetric and more extensive PVL. What happens? Both the lower limb and both the upper limb fibers are affected. So what happens? There is tetraplegic CP. So our mechanism of diplegia, triplegia, and tetraplegia are the same only. It is PVL, but one is normal PVL, second is asymmetric, more extensive PVL, and the third tetraplegic is bilateral, symmetric, extensive PVL. You understand? That is the mechanism. The mistake that that was there in the answer of Vengi tried to answer very, very good. That I appreciate. But the mistake was that when you are saying triplegic CP, there is only two lower limb and one upper limb. It is not the other way. Two upper limb. You can say triplegia. I hope when you understand that you can say triplegia, hemiplegia, quadriplegia, etc. So triplegia, you can have another combination of two upper limb with one lower limb. Two upper limb with one lower limb. This is a peculiar situation. Can you tell, I mean, from your experience in MBBS, etc., where this situation, where the localization of such a problem, where triplegia with both upper limbs involved, followed by one lower limb. First two upper limbs are getting involved, then one lower limb is getting involved. So just I will give you 30 seconds to think and answer. Otherwise, I will tell. What is it? It's CV junction. It is CV junction lesion. Craniovertebral junction localization lesions tend to produce different types of paralysis that you know. Cruciate paralysis, U-shaped paralysis, and Z-shaped paralysis. In Z-shaped paralysis, when it begins, the upper horizontal bar of the Z forms, producing by both upper limb. Then it crosses over to involve the right lower limb. So it is called Z-shaped. In the beginning of Z-shaped paralysis, you may get a triplegia. But when you are saying triplegic CP, that means two lower limbs are compulsorily involved plus one upper limb. So that was so other things. Another refinement I would like to make in your answer is regarding quadriplegic CP. No, tetraplegic CP, where you said the upper limbs are more involved than the lower limb. That is not correct. They're actually equally involved. If at all you see by the mechanism, if at all the lower limbs would be a little more involved than the upper limbs. But usually they are almost equally involved. There is nothing like upper limb being more involved than the lower limb in tetraplegic CP. And can you, has anybody else joined, like Gobi or Divya joined? No. Then I will direct to Varun. Varun, one thing. What is the type of pathology in CP, neuropathology in CP, where you get this? What do you say? Upper limbs are more involved than the lower limb in a quadriparatic or a quadriplegic CP, with upper limb more involved than the lower limb. What is that pathology called? One pathology we said periventricular leukomalacia. Disconnected CP is produced by status marmoritis. What is the other pathology? Very, very interesting pathology which produces a quadriplegia with pathology which is rare actually, with quadriplegia with the upper limbs more involved than the lower limbs. It's a very rare situation. No, it is called a double hemiplegia. Double hemiplegia. What is that? It's very rare type. So I am not discussing it here. We will go over to our further neurodegeneration topic. We are not discussing that. But I just wanted to correct certain things. Another thing that he answered, Vengi answered, is quadriplegia. All the four limbs are no. Vengi, you should say like this: the whole body is paralyzed in quadriplegia, while only four limbs are affected in tetraplegia. This is the question usually asked to me by my PGs, where they ask, sir, what is the difference between tetraplegia and quadriplegia? They look alike. No, tetraplegia, only four limbs are involved. Everything above the neck is normal. In quadriplegia, the whole body is affected. We will discuss those aspects later in our future CP class, inshallah. Okay, you continue. We were discussing till enteral feed started on postnatal day 7 with express hospital. That, okay.
And palliative feed was started on postnatal day 30. No step in feed intolerance or recurrent vomiting. No step in hypoglycemia, seizures, or neonatal hyperbilirubinemia. Baby discharged on postnatal day 45 with a discharge weight of 1.2 kg.
Okay. So there were nothing to suggest any metabolic problem, etc., in the newborn period, except for the prematurity and the associated problems. Okay. Okay. And the marriage was also non-consanguineous.
No, sir. A consanguineous marriage, third-degree consanguineous marriage.
Oh, consanguinity, sir. Okay, okay. But there was no indication other than the decreased fetal movement. Nothing was abnormal till the premature labor occurred. Okay.
Yes,
oh, okay, sure.
Baby was on palliative feed on the time of discharge. KMC continued, direct breastfeed initiated by postnatal day 60. Mother noticed a decreased spontaneous movement as compared to her sibling. Mother also noticed a feeding difficulty in the form of increased feeding time. At 5 months of age, baby became alert to sound, started smiling, looking at face. At 7 months of age, baby had head control, started to approach objects with both hands, was able to verbalize mother, could make moving sound. Mother noticed a delay in attaining milestones compared to elder sibling at by 8 months and consulted at a local hospital and was informed that the delay is due to prematurity. At 9 months, baby was able to roll over, was able to approach the object with one hand, started making sounds like ma. At 10 months, the child was able to sit with support. No further milestones were attained after 11 months of age. By 1 year, 1 month, the child was taken to a hospital in Tirunelveli in view of a delay in attainment of milestones. MRI brain was taken and was said to be normal. Some blood investigation were also done, which were also said to be normal. Baby was advised to do physiotherapy from home.
Can you show the first slide of that development 5 months? That
Fine.
no after this I said this one 1 minute. 1 minute. Notice decreased spontaneous movement as compared to her sibling. Mother noticed decreased spontaneous movement as compared to her sibling. Was it in the less than 4 months?
Yes, sir.
Okay.
Yeah, immediately after getting the baby to her
So,
hand, she noticed that decrease of spontaneous movement of the baby
as compared to the other sibling. Okay.
Yes, sir.
Okay. That what are the possibilities of that? I mean, what are the localization possibilities of that?
Less than 4 months, the movement is controlled by at the spinal level.
Brainstem.
So,
It's at the brainstem level.
Brainstem level.
Okay. So actually, one thing we can say is that because the child has suffered a lot during the preterm, that is after the birth period, might have suffered hypoxia. So the brain would have been dysfunctional because of that. That can also lead to decreased activity and obtundation of sensory and other things that we can say. Then another thing, it is this decreased spontaneous movement is one of the red flags of CP also. That also we can say. Another possibility is that we can in the context of this consanguinity, we can also think of a underlying metabolic disorder which may be causing the decreased spontaneous movement, because metabolic disorders tend to be having decreased spontaneous activity. And the fourth possibility is that the patient was later having delay. So organal disorders like mitochondrial disorders, etc., may also present with the decreased spontaneous movement. And the fifth possibility is that there could be, like a, mix. If the child is also having hypotonia, it could be like a mixed floppy picture where there is involvement of central plus peripheral. And mixed floppy, few causes are only there: mitochondrial, peroxisomal, then this congenital muscular dystrophy, etc. All have to be thought of. So even this simple complaint is very relevant for because it raises possibility of 4 or 5 etiologies, which could have been investigated at that time itself. Okay. Then at 5 months, baby became alert to sound. Increased feeding time. So when she is complaining of increased feeding time, you should ask why the feeding time was increased, because even in congenital cardiac failure, feeding time could be increased with the sweating. So you should ask what was the difficulty? Was it that the child was unable to swallow, was keeping the food for a long time in the mouth, or unable to swallow, or was there any tongue thrust, or the child's head arching, etc. in the case of CP? Or you could ask whether it was having choking spell, so the mother was very careful. Those things you can ask at this juncture.
Mother had told that the baby was sucking poorly.
So when the mother complains like that, you should differentiate what was the sucking problem. Was it because the child was not very conscious, always sleepy, drowsy, or was it that the child was not able to exert adequate pressure on the areola by opposing the mouth to the areola, as well as develop respiratory power to suck this. So both these are important because the first component is important in the case of congenital myopathy and the LM and floppy things. And the second thing I told, the respiratory power is not, that may be relevant in case like SMA and other things where the respiratory muscles are more involved. So when the mother is saying sucking was difficult, you should ask her what was the sucking difficulty. Was it that the child was obtended and not very interested in feeding and turning away the head, etc., like that, or was it because the child was trying to feed but was not able to develop adequate sucking pressure? So these two differentiate between two localizations. One is central localization and the second is peripheral localization. Okay. Okay, you can. And the thing with the problem with the IEM is that, see, we are not thinking about IEM even now, but the thing is, if the thing with IEM is that both may be altered. You see, inborn error metabolism affects both the brain as well as the peripheral tissues. Both may be sluggish. That aspect also we can think of in the background of consanguinity. Is consanguinity important in any other setting like element? Consanguinity is important in element, floppy, or some. What condition? Consanguinity. Most common, most important condition. SMA.
SMA.
Only SMA. Second, which condition in the localization? Peripheral. Congenital myopathy. Certain types are autosomal, certain types are autosomal dominant. So difference X-linked. So difference is there. Okay. At 5 months, baby became allowed to sound, started smiling. 7 months had head control, approached objects with both hands, able to recognize mother. A child was slowly making progress. Just like that of usually a CP child getting better with good care and okay. You can present. Next slide. There was one point in at 10 months, the child was able to sit with support. Sit with support. Okay. What is the relevance of sitting without support at 1 year for a CP child? Sitting without support. The mother says that the child, we had some hypoxia, so CPU developed, and child was able to sit without support at 1 year. Is there any relevance for that statement as far as prognosis is concerned?
The baby will be able to walk most
Okay,
probably.
okay, very good, very good. That is within 4 years, if the child is able to sit without support, the child may walk. But that walking time we cannot predict. It depends on a lot of other factors. And also supra-adult insults like CNS infection, systemic infection, etc. Okay, you can go to the next slide. And you are actually presenting the developmental history, isn't it? Developmental history.
Yes, sir.
Okay. Okay. Along with that, I think along with the development history, I mean, just saying only, you could also ask regarding another other 4 important things, and you can mention just negative or positive. One is, was there any seizure? That is one thing. Seizure. Second thing you ask regarding tone. How was the baby feeling in the mother's hand and when handling and taking bath? Was the child having a feeling, mother having a feeling of floppiness or a flail child, or was the mother having a feeling of stiffness? These are very important for localization. I hope you understand. In the case of IEM or neurodegeneration, both things can occur. In that also, like CP, both things are occur. You know, CP has various types where tone may be increased or decreased. Like that, IEM and neurodegeneration also, you can have either stiffness or floppiness. And they may point to certain etiologies also. So that is one thing that you left out. Please note it down so that next case we can ask that also. Oh, you're coming. You are coming to that. Okay.
Yes,
Then
yes.
the next thing that you should have asked is like vision and hearing also, along with the motor development. You have said very good regarding motor development and the other development. Vision and hearing also you ask when it developed. Okay. Okay.
No further milestones were attained
Attained
after 11 months of age.
It is stage of plateau achieved. A stage of plateau.
Yes.
Okay.
Yes. By 1 year, 1 month, the child was taken to a hospital in Tirunelveli in view of a delay in attainment of milestones. An MRI brain was taken and was said to be normal. Some blood investigations were also done, which were also said to be normal. The baby was advised to do physiotherapy from home. At 1 year, 3 months of age, baby had a fever, which was managed symptomatically with the paracetamol medication. Following this episode, mother noticed the child has lost the ability to sit with support and stopped vocalizing sounds like ma, and the baby had only rollover and having excessive drooling of saliva.
Oh, okay. Okay. That 1 year, 3 months was that event that occurred. Okay. Now, we had delay. We did not have regression up to now. What are the causes of pseudo regression in CP? Pseudo regression, 3 or 4?
Spasticity and
No, I'll ask Vengi because he alone is present. Vengi, what 2 or 3 causes of pseudo regression in CP? Cerebral palsy.
Increase the spasticity of the muscle.
No, first you should not tell that. First you should tell seizures, new onset seizures, or you can tell like from a systemic illness like pneumonia, or a severe systemic illness like pneumonia or sepsis, which leads to regression. Then third, you can tell CNS infections, and fourth, you can tell use of drugs like baclofen or sedative drugs like pheno, etc., which may decrease the muscle power and tone. And next, then you can tell if the child is unattended by the parents and not subjected to physiotherapy, contractures may develop, which may lead to difficulty in sitting as previously. For example, hamstring contracture developing can have the child fall down when trying to sit. You understand? So this is how you should tell. First, infection, systemic or CNS infection, seizures, new onset movement disorders. I think at last class I told you regarding a child who came with spasticity. I gave baclofen. He became better, but after 8 months, he again began to develop hypertonia and seems to regress. And so that is actually rigidity superadding on spasticity. So you can tell the increased tone thing last. Okay. Varun, continue.
at 1 year, 3 months, the baby had a fever. Following that, lost previously attained milestones. At 1 year, 6 months, the baby ceased to roll over from when lied on bed. I was not able to reach on to objects with both hands. Was still able to recognize mother. The mother noticed stiffness of both lower limbs. The child was allowed to sound with a startling response, with both hands moving out on its hearing sounds. The child was then taken to a neurologist. MRI brain was taken at 1 year, 2 months, and was said to be abnormal. Advised to do a genetic test. Parents thought the child will improve by physiotherapy and
Okay,
follow.
one question in between. That is, how does regression, neuroregression, other than this true regression? I'm talking about true regression. What are the types of presentation of true regression? 2 types of presentation. 2 types neuroregression.
After a Plato phase, the child having a
No, the thing is one is a normal development followed by regression.
okay.
Example, in the case of metachromatic leukodystrophy, certain groups of children in metachromatic leukodystrophy may develop normally till 1.5 years, then they develop clumsiness, etc. There is another group of metachromatic where the child will have some delay, but he will attain walking by 1 year, 3 months, or 1 year, 4 months, and after that, 1.5 years. After 1.5 years, he may have clumsiness, falling like that. So both are there. So a true regressive disorder can present both ways, with the normal development followed by regression and delay followed by regression. So the initial delay is not a point against the true regressive disorder inside. Then another thing, what is the suppose we take a true regression, what are the type of regression? That is, we said regarding delay followed by etc. That is one aspect. When the child regresses, how can the child regress? There are 2 types of regression types. One is continuous regression. I will tell because of lack of time. I will tell. It is sloping regression. You can say sloping regression, where the child continuously regresses. And another type is where episodic regression. Episodic regression, where the child gets some infection or a stress or something, and the child regresses and then remains at that level. And again, when the next infection or something comes, again it regresses. So if the child remains at that level after regression, it is called a stepwise regression. Suppose in certain children, for example, certain children with the mitochondrial disorders, they tend to regress with infection, but then because we are giving supplements, etc., they will attain some capabilities back, and then they will remain at that level. Later, when another insult develops, again they will regress. This is called a sawtooth regression. where the shape is not that of a step, it is like that of a sawtooth regression. These are two types of episodic regression. Our diseases of interest like Niemann-Pick disease, Gaucher, Tay-Sachs, etc., they usually tend to have a sloping type of regression. Under the really true neurodegeneration, large molecule defects, storage disorders, etc., they tend to have a continuous sloping regression. But the pattern here is not that much fitting with this thing. But even then, we can say why the plateau phase. Okay, why there is a initial. No, sorry, why the plateau phase occurred in between? Can you explain? In the nervous system, the plateau phase that you told between 11 months and 1 year 3 months, there was a 4-month period when there is a plateau phase where the development remained still.
The degeneration may have initiated.
The anabolism of the body, the growth, the developmental growth tendency of the nervous system, the connections, etc., actually equaled the damage. So actually, it was remaining plateau. The deceleration produced by the neuroregression was matched by the acceleration, developmental acceleration produced by the anabolism or the growth. It's called trophic, the growth pattern of the brain. So that was matched, but then it overtook. When the infection came, everything the decompensated. So when an infection comes and suddenly the child becomes goes down, what pathogenic pathophysiology mechanism comes to your mind? What type of disorders come to your mind when an infection comes and the child which was having a plateau of development suddenly regresses with the loss of all milestones? So what type of pathology or etiology, that tempo of the disease will give an idea regarding the etiology. Localization is given by the combination of symptoms and signs, while the tempo of the disease gives you an idea regarding the etiology. So this is a tempo where initially delay was there. That delay we can attribute to even prematurity with hypoxia, but later on plateauing was there. Then after plateauing, again the child suddenly regressed following an infection. So what are the etiologies it points to? Can you tell group of disorders?
Mitochondrial disease.
One is mitochondrial energy metabolism defects, and the second is this inborn erasure metabolism. So one question to Venkat is, what is the difference between the common neurodegenerative disorders and inborn erasure metabolism, the sloping regression types and the inborn erasure metabolism? Tell me two differences.
So in inborn of metabolism, symptoms will be established soon after the feed has been established. They will have some acute decompensation
that's a very good thing. The third day or the fifth day, I mean, the feeding, after feeding is started, extraneous feeding is started, symptoms may start. But Vengu, there are a lot of conditions who do not present. For example, like urea cycle disorders, mitochondrial disorders, which may not present at birth period. So what happens? What is the other difference between neurodegenerative disorders like Tay-Sachs, Niemann-Pick, Gaucher, and the IEM defects? There are two major differences.
IEM may have failure to thrive.
No, I not the clinical difference, the mechanism difference I'm asking. Clinically, sometimes very difficult to differentiate between IEM and neurodegeneration. For example, glutaric aciduria is a IEM, isn't it? But it can also present like a neurodegenerative disorder. So sometimes very difficult because MSUD may look like a CP sometimes, but then it may regress. So we'll think that it's a CP mimic. It's actually CP mimic. Some patients with MSUD. So there is a lot of overlap there. But I am asking the molecular mechanism. What is the molecular difference? Inborn erasure metabolism are intermediary metabolism defects where the small molecules are involved. The enzymes converting small molecules are involved. That is also the consanguinity risk factor. But neurodegeneration is where there are more of a large molecule defects. Large molecule storage. What happens is that enzyme is lost. There is a storage of a large molecule in the lysosome or inside the cell, leading to toxicity. You understand? So that is one major difference. Second difference, the true neurodegenerations like Niemann-Pick, etc., continuously regress. There is a sloping type, while the IEM may tend to have a episodic regression. These are the two. One is type of regression, and the second is the molecular type. Okay, that differentiation that you should try maximum not to mix up with IEM with the neurodegeneration. Neurodegeneration means when we are saying neurodegeneration, we are meaning Tay-Sachs, Niemann-Pick, Gaucher, etc. Okay. At 1 year, 6 months, baby ceased to roll and up, not able to reach on to objects. Mother noticed stiffness. Mother, there is a new complaint here. Baby was still able to recognize mother. Mother noticed the stiffness of both the lower limbs. And the child is alert to sound with the startling response, with both hands moving out on hearing sounds. That is, even a small sound is able to make a startling response.
Not very small sound, but when someone laughs and all.
Okay. Okay. This type of starting, can you give two differential diagnoses? Why don't? Because Dia and Gopi are not there, I am asking. Sorry for troubling you unnecessarily. Okay.
Tay-Sachs disease.
And one more.
Then Krabbe's disease, GM1.
Krabbe, correct. Krabbe and Tay-Sachs, both where there will be increased this alerting response. And this Krabbe may also have hyperacusis. And these conditions may also have a phenomenon called hyperacusis. So hyperacusis and increased startling responses may be seen in Krabbe and Tay-Sachs. So this is one clue actually. The startling response. And mother noticed the stiffness of both the lower limbs. So when mother is noticing a new onset stiffness of both the lower limbs, what is the localization? Localization is the lower limb fibers traversing the brain are getting involved. And so what can we think of? The pyramidal tract arising from the pyramidal cortex while traversing the brain is getting involved in some way. Because what is the local? These lower limbs are getting involved. So what could be the possible localization? One is spinal cord, but we are not thinking about spinal cord because we know that the child's brain is affected. Second localization is the periventricular fibers coming down that are getting involved. So the mechanism we don't know. We have to take an MRI and see what is the mechanism. What are the mechanisms by which the periventricular fibers may get damaged? Mechanisms. One is by demyelination, like you said, demyelination. You know the difference between demyelination and demyelination? Demyelination is acute conditions like ADM, multiple sclerosis, etc. Demyelination is a genetic defect is there, because of that the myelin becomes dysfunctional and gets destroyed. So demyelination, correct, you are correct. There is one mechanism is demyelination. Second mechanism, pressure. The pyramidal tract in comparison with the spinothalamic tract is highly sensitive to pressure. So first there will be pressure dysfunction, then there will be pressure demyelination, and then there will be pressure necrosis. So these are the mechanisms by which the pyramidal tract gets damaged when something presses on it. Especially this is useful in the analysis of spinal cord conditions. But this is applicable to periventricular fibers also. So pressure, so you have to think of when such a thing happens, you also have to think of the possibility of hydrocephalus, a new onset hydrocephalus developing. So can I ask a very difficult question to Vengi? That is, what condition, what leukodystrophy can cause simultaneously hydrocephalus also? Leukodystrophy causing hydrocephalus.
Canavan.
Not Canavan, it is Alexander. Alexander has a tendency to produce such a thing. That is leuko. But here, mother noticing both lower limbs may be the beginning of a leukodystrophy. But you see, whether the initial setup agrees with the leukodystrophy, yes. There was a delay in myelin may be forming dysfunction. Initially, there may be delay followed by only point against a leukodystrophy. What is the point against a leukodystrophy?
Early onset is against it.
The thing is, with the infection suddenly deteriorating, you see, that point is against most of the leukodystrophy. Leukodystrophy is present by their own. They don't need any infection or any major insult for presenting, except one condition, which can have initial normal development or mild delay in development followed by regression following trauma or infection. What is that? Leukodystrophy. It's a rare leukodystrophy. It actually vanishing white matter. Correct. Vanishing white matter can sometimes present like that, but here you see that all the milestones are getting lost because of one simple infection. The infection is not that powerful enough to produce all the regression. So that means that's a point against a leukodystrophy. So what else what else with the involvement of the pyramidal tract bilaterally? What other metabolic disorder comes to your mind with this, which can present later, which can initially present with the delay, later it can present with the increasing stiffness of lower limbs, followed by increasing stiffness of upper limbs. IEM.
Zellweger syndrome.
Zellweger, no. Zellweger, what is the problem? Floppy, baby. Zellweger is floppy. So, very common group of disorders. Five diseases are there. The initial enzymes are very severe. The later enzymes are less severe. A material expelled through urine.
Maple syrup.
Urea cycle disorders. Urea cycle. See, urea cycle disorders, the later forms, the arginosaccinic aciduria, as well as the arginase deficiency, etc., they tend to affect the white matter more. Even though arginosaccinic aciduria will affect the gray matter also, but arginase deficiency tends to affect the white matter. But the presentation is, what is the presentation of arginase deficiency? Usually, it can have various severity. Usually, it is a CP mimic. I know. It is a spastic CP mimic. It exactly looks like a CP. When do you suspect that the patient has arginase deficiency? What is the pointer? Varun is seeing that patient for the last 2 years. Okay. You are advising physiotherapy, baclofen and everything. But when Varun sees, even after 1 year, there is no improvement in the spasticity. Even with 5 days physiotherapy and medicine, no improvement is there. That makes you suspicious. Is it a CP mimic? Because CP should improve, isn't it? So that is when you suspect arginase deficiency, biotinidase deficiency, etc. But Vengi, biotinidase, if you think, what is the point against? Biotinidase will be a little more severe, as well as it will have this alopecia. A classical feature is alopecia. Can you tell me the best, one of the best vitamins for hair loss, both for useful for males as well as females? One of the best vitamin combinations. A lot of them. Biotimic. We should not tell brands, but just telling one of the things is biotimic, which is very useful. I have tried in various patients. So biotimic is that biotin is very important for hair. So this patient actually, the diagnostic possibility when we read the mother notice stiffness of both lower limbs with the regression following an infection, the possibilities are an IEM like an urea cycle disorder. Can we think of mitochondrial at this junction? This is a frank question to Varun. Can we think of mitochondrial disorder with the available history of initial delay followed by a plateau phase followed by regression following illness? Is there a possibility of mitochondrial disorder?
Yes, there's a possibility of mitochondrial disorder.
Definitely mitochondrial disorder is possibility. But is there any point against that, a comparative point against that in the slide that you are showing? Stiffness of both lower limbs. No, the stiffness of both lower limbs. Mitochondrial per se does not produce a leukodystrophy per se. It can affect in various ways. It usually, what is the most important organ? Inside the brain, in the nuclei inside the brain that is affected by mitochondria. Most important nucleus affected by mitochondria. And why is that? Among the gray matter, the cortex, gray matter, the cerebellum, gray matter, the basal ganglia. Among the three, which one does mitochondrial disorders tend to affect more? And what is the reason? Reason is given in Swayman. What is the reason? Basal ganglia. Mitochondrial disorders generally tend to have a predilection for basal ganglia. They do not have a predilection for white matter, usually. Because basal ganglia is high energy metabolism, so they are fast affected. So the point that mother noticed stiffness of both lower limbs, which was not present previously, is slightly a point favoring a leukodystrophy or a leukoencephalopathy. Leukoencephalopathy is whatever disease affecting white matter rather than a mitochondrial. That's only one point. But we will, by God's grace, we have now, Vengi, please note down the differentials. One is mitochondrial disorder, I fully agree. Second is urea cycle disorder. And the third, the possibility is that we were thinking is a beginning of a leukodystrophy, like Krabby. So this beginning, Krabby usually presents at what age? Less than 6 months.
3 years.
So less than 6 months. So even here the regression is presenting after 1 year. So that will be late infantile. The type of Krabbe will be late infantile type. Okay. So, okay, with both hands moving out on hearing sounds, child taken to a neurologist, MRI taken at 1 year was said to be abnormal. Advised to do a genetic test. Parents thought child will improve by physiotherapy. Hence follow. Genetic test paisa and up already can. What is the cost in Kottayam? 12,000.
12,000.
Oh, very good, very good. Here also same only 12 and 10,000. Now it has decreased from previously they were saying 20,000 like that. Now it has decreased. Okay, so MRI brain taken at 1 year, 2 months was said to be abnormal. We don't know the details. It is better that we don't know the details because we'll be biased if we hear the MRI. Whenever a patient comes referred from a center, if it is not an emergency, always take the history and examination by your own so that you can develop your own idea. Then only look at the MRI. If it is an emergency, immediately look at the films and other thing and the order sheet, etc. Okay. Okay. Next slide. So I will also note down the differential diagnosis here. One is mitochondrial disorder, very possible. The consanguineous parentage is there. Second is urea cycle disorder. Third, we thought of biotendinous, but it's less likely. And the third one, what that we think was leukodystrophy, beginning of a leukodystrophy with the alerting sound, and among them, Krabbe being higher possibility. Varun, one simple question: what is the usual presentation of this metachromatic leukodystrophy? Usual presentation, because that is the closest, one of the closest mimics of CP.
Usually presents by about 5 years with ataxia.
No, metachromatic, not adeno, metachromatic.
With the poor scholastic performance and.
No, I was saying about leukodystrophy, metachromatic leukodystrophy. You are actually telling the features of adrenal leukodystrophy. This is a female child. Wengi, metachromatic leukodystrophy. I just recently said only. So I should not ask the question. I told just a few minutes back.
There will be clumsiness of the movement.
Yes, that is up to 1 year and 6 months or so. Usually the child is normal or only mildly delayed. But the mental faculties are also all perfect. The social development, language, etc. perfect. But after 1.5 years, you tend to notice clumsiness and recurrent falls. Then there will be like walking difficulty, followed by you notice spasticity and ataxia in the lower limbs initially, and then it will spread to the upper limbs also. So I will tell you, I mean, just for on additional tip only, I saw a metachromatic leukodystrophy at the age of around maybe like 2 years. He was actually not able to walk, he was able to walk with support only. In the next year, I am seeing he's sitting only. He has lost the ability to walk. And the next year, I am seeing he's lying. He has lost the ability to sit also. And the next year, he developed seizures and vegetative state. So that is how the metachromatic leukodystrophy progresses. It's a real case. I saw during my initial working at the pediatric neurology, 2006, that period. Okay, you are correct only. So one aspect why we are not thinking about adrenoleukodystrophy is that this is one important. It says female child, isn't it? Female child. Adrenoleukodystrophy. When Varun said regarding this adrenoleukodystrophy, I have one question for Varun. Varun, you were saying the features of adrenoleukodystrophy. What is it that differentiates adrenoleukodystrophy from the other leukodystrophies in the presentation? What is the difference of adrenoleukodystrophy when compared to the other dystrophies?
Usually presents around 5 years.
Yes, between 4 to 10 years of age or 4 to 8 years of age. Correct. 5 to 6 years of age. What is the? It's a male child. What is the important difference between the presentation of adrenoleukodystrophy when compared with the other leukodystrophies?
Behavioral changes may be present.
Yes. That is neuropsychiatric. That is academic deterioration, psychotic features or other psychiatric features, and also this loss of speech, the proper understanding ability, auditory agnosia, and then only the patient develops seizure. Patient can also develop seizure. So the loss of speech ability, academic deterioration, seizures. What these features, what does it suggest? Does it suggest a gray matter disorder or a white matter disorder? Gray matter neurodegeneration or a white matter neurodegeneration? Not in this patient. With the features that you are telling, academic deterioration, poor scholarship performance, decrease in speech, decrease in hearing.
Suggest a gray matter disease.
Yes, that is the point. Adrenoleukodystrophy is a masquerader. It may masquerade like a gray matter disorder, and you may even think about SSP, isn't it? Because SSP also initially presents with the academic deterioration in academics, and later dominated by myoclonic jerks. Okay, here the usual. What is the reason, Vengi? What is the reason for this seizures in that this adrenoleukodystrophy? What is how can you explain? Because seizures are very unlikely in leukodystrophy. What is the reason for seizures in adrenoleukodystrophy alone?
Maybe extreme demyelination.
Do you remember? I mean, if I take a contrast CT of a child with adrenoleukodystrophy, 7 years old, some progression has come. So, what will be that typical appearance? A flying thing appearance. What is that appearance? A contrast CT I take in a child with adrenoleukodystrophy, not contrast MRI, contrast CT, and there's a typical appearance is there, a peculiar appearance, butterfly pattern. I will do one thing. I will transfer on PowerPoint to that one I prepared for a small neuro club. That PowerPoint to Thomas. You please go through it when you get time, both of you, and give to Nivya and that Gobi also. Let them also understand regarding the leukodystrophy. It's very easy to differentiate leukodystrophy in your clinic and investigation when you get that. Go through that PowerPoint. Okay. So that is one thing. Adrenoleukodystrophy is not like. Then there is one thing that God reminded me that what is that you said like all the abilities were lost after this regression, isn't it? Not only the motor ability, but
yes,
the other abilities like speech, looking at the mother. I mean, lot of things regress, isn't it? So our I am asking only in an innocent manner. So the third one, leukodystrophy, we considered Krabbe, etc. Is that possible in Krabbe?
Usually cognition is not affected earlier.
No, in metachromatic leukodystrophy, usually cognition is not affected initially. It is affected later only. But in Krabbe, there can be psychomotor regression. And initially Krabbe and Tay-Sachs may look alike, but the only thing is that Tay-Sachs will have hypotonia, while Krabbe will have hypertonia. That is more dominating. So even the point that everything regress is not a point against leukodystrophy. It can happen in Krabbe, but still I will consider another condition rather than leukodystrophy with that history, whole thing regressing. So in that aspect, can you write down a few things which one question I failed to ask you, that is regarding global regression, 2 or more developmental domains regressing is global, and sometimes one alone can regress. Like for example, language regression. What is the condition causing in language regression? And what is the condition causing language and social regression?
Language regression alone can occur in a Landau-Kleffner.
Very good. Landau-Kleffner. Correct. Thank you. And what is language and social regression together? One important condition that I am treating a lot of patients with that. I am mainly my focus is on those patients nowadays. One very powerful condition, but which can be recovered fully. Autism. Yes. Ruby has answered autism. Autism is where language and social abilities regress, while language regression alone can occur in Landau-Kleffner syndrome. In what are the two presentations of Landau-Kleffner? One is language regression. What is the other presentation? Seizure. LKS, a peculiarity of LKS is that LKS can have seizure initially, followed within 2 years by language regression, or it can have language regression initially, followed within 2 years by seizure. So there is a type of locking of the features. Okay. Then now let us go to the next. Okay. I was going to tell regarding isolated motor regression. So isolated motor regression, I will tell you by the localization from above downwards. You can just note it down because of lack of time. I'm not asking. First is leukodystrophy. Second is spinocerebellar ataxias, SCA. Here the localization is to the cerebellum. Third is movement disorders affecting basal ganglia. They may initially have motor regression, later other things regress. And the fourth localization is spinal cord, myelopathy, which could be two types, compressive or non-compressive. And the next localization is anterior horn cell. That is, the motor neuron or the SMA group of disorder. For example, juvenile SMA. Okay. Then the next thing is nerve. Nerve is, hereditary motor sensory neuropathy, or usually HMSN is likely to regress after initial normalcy. Then any other thing regressing, any other motor is congenital. But the thing is, congenital muscular dystrophy, congenital etc. delay will be there. Already delay will be there. So it's not so much like that. But the things which are normal and regressing later on is up to this. Okay. Okay. So motor regression can happen in these conditions. Isolated motor. So we'll continue with the presentation.
By 1 year, 9 months, the child was not able to hold the head up. Stiffness of lower limbs had improved by physiotherapy. The child stares at the light source, was allowed to sound with the startling response. Mother noticed the child had a tongue thrusting on feeding. Newspaper regurgitation of feed. There was a decreased interest in surrounding and poor response when called. The child was not improving, came for consultation at our hospital.
Okay, now the child has shown mild improvement, isn't it?
Mild improvement in the stiffness of lower limb.
Okay, that is you don't think that there is a lot of improvement. It's at least remaining the same after the regression.
Yes, the child has also lost the ability to hold the head up.
That is persisting, but you are saying like child looks at the light source. That means child did not look at the light source previously, or was it the same only?
No. Yeah. Earlier the child was looking at the mother, and now the child is not.
Okay. Then it is so everything is regressed and it is remaining the same only. Okay.
Yes.
Okay. 1 year 9 months, 1 year 6 months, everything lost, and 1 year 9 months, the same thing is persisting. But between 1 year 6 months and 1 year 6 months and
child was able to hold the head up, but had lost the ability to roll over. But 1 year 9 months only, the child was not able to hold the head up.
And also child is not looking at the mother also. That means both the motor as well as the psychomotor things are regressing. So it is continuously regressing now. It is continuously regressing. Okay.
Noise in abnormal posturing or jerky movements of limb. Noise in irritability or excessive crying. Noise in abnormal eye movements or spin. Noise in deviation of jaw and opening of mouth. Noise in deviation of angle of mouth.
What is the relevance of ocular eye movement abnormality? Like ocular palsy or ophthalmoplegia, any relation to our differential diagnosis?
It can occur in crampy ophthalmoplegia.
Okay, then anything else?
Then
mitochondrial disorders can have ophthalmoplegia, but usually there is another condition called CPE where only ophthalmoplegia is prominent, but mitochondrial can have ophthalmoplegia. Okay.
Nose in deviation of tongue on protrusion, nose in abnormal tongue movements, nose in involuntary movement of extremities, nose in hand wringing or hand washing movement, nose in difficulty in changing diapers.
While feeding, tongue thrusting is there, but other no choking during feeding, no nasal regurgitation.
No regurgitation of tongue.
Okay.
Nose in difficulty in changing diapers, nose in appreciable variation in head size.
One thing that you should ask is 1 minute. I'm decreasing the size. 1 minute. Automatically it increases in history of presenting illness. So regarding the stiffness of lower limb, you should have asked the mother whether the stiffness disappeared completely in sleep or part persisted. That's a very important question. Why?
Dystonia may.
No, you have to differentiate between spasticity and rigidity. The localizations are different. If it is rigidity, the localization is basal ganglia. Then we can think of not only mitochondrial, we can also think of other disorders like PCAN, you know, that pantothenate kinase deficiency, Leishman, those types of etiologies also come into view. So it's very important. Next time, please ask mother whether the stiffness disappeared completely during sleep, or and also one more question you can ask, whether the tone, increased tone in the lower limbs was variable. Variable meaning while the mother is taking in lap, it is decreased. If somebody else takes in lap, it is very much increased, sudden increase. And when hearing music, it suddenly melts away. Hearing soothing music, it suddenly melts away. That is indicative of rigidity. Rigidity only has that type of characteristic. Spasticity does not. Spasticity remains uniform. Usually, it does not change. But in deep sleep, a reduction may be there, but it will not disappear. This is a very important point. We need to retrospectively ask the mother, because we are curious whether the white matter is involved or whether the basal ganglia is involved, because that will give us an idea regarding what direction we should go in the etiology. Okay. No history of abnormal tongue movements. No history of one minute. No history of involuntary movements of extremities. So that is very good question, because if we are suspecting basal ganglia, if any involuntary movement should have come, it should have come by now, isn't it? The reason is usually if there is immaturity of the myelin, or if there is hypomyelination associated, it need not come. But if the pyramidal tract is mature enough, the involuntary movements should have come by now. But no involuntary movements are noticed. Okay. No involuntary movement, no history of any hand wringing or hand washing movement. What does that condition signify? That is usually in female. But in Rett syndrome, what happens is that a normally growing child after 1 year regresses with the loss of eye contact, etc. No history of difficulty in changing diapers. No history of appreciable variation in head size. Okay, you can continue. No history of abdominal distension, Eli's discoloration of eyes, skin pigmentation,
abnormal skin
pigmentation or abnormal hair color. And also, okay, that we can examine. Okay, hair we can examine. No history of what is the type of hair abnormality in arginosaxenic aciduria and in Menkes disease?
Menkes, it will be a frail hair.
That is, it will have trichorexis nodosa. On microscopic examination, it will be like എഴുന്ന് നിൽക്കുന്ന hair പോലെ ഇരിക്കും. എഴുന്ന് നിൽക്കുന്ന നമ്മുടെ രോമാഞ്ചം വരുമ്പം മുടി എഴുന്ന് നിൽക്കത്തില്ലേ, അതുപോലെ ഫ്രൈൽ ഹെയർ ആയിരിക്കും, പക്ഷെ അതിങ്ങനെ എഴുന്ന് നിൽക്കും, കുറ്റുപോലെ നിൽക്കും. മറ്റേ ഇതിലെ അർജുനോസാക്സനിക് അസിഡോറിയയിലോ ഭയങ്കര എക്സസീവ് കേർലിംഗ് ആയിരിക്കും. എക്സസീവ് കേർലിംഗ്. അതിന് കളർ ചിലപ്പോൾ കളറിനും ചിലപ്പോൾ ഒരു ആൾട്രേഷൻ, ബ്രൗണിഷ് കളറേഷൻ വരാം. എക്സസീവ് കേൾസ് ആയിരിക്കും, ഭയങ്കര കേൾഡ് ആയിരിക്കും ഹെയർ. No history of recurrent respiratory. What is the type of hair abnormality in mucopolysaccharidosis? It is actually, like you said, it's a coarse, easily damageable hair with the abnormality in the texture. The texture may be sometimes very shiny, sometimes very rough, like that. Okay. It is not very pathognomonic. It can occur in a lot of conditions. So no history of recurrent respiratory tract infection, and no history of abnormal odor of urine, and no history of sucrose cycle forehead setting. Okay. Okay. The cardiac complaints are also not there. Okay, you can proceed.
Coming on the past history, at 8 months of age, the child was admitted with a pneumonia at a private hospital in Montreal for 7 days. IV antibiotics were taken, did not require any oxygen support.
But at that time, child did not regress. That is, even with the pneumonia, at that time, child did not regress. Okay.
No.
Okay. So tell me one condition which usually tends to regress at around 9 months with the, following an infection, with the loss of all acquired milestones, and which later presents with the involuntary movements. An IEM.
Leigh syndrome.
Leigh syndrome. You're right. Leigh can present with this problem at any age, like 9 months, 1 year, 1 and a half, like that. But 9 months on peculiar condition. Usually at 9 months of age, my mother complains that the child had an encephalitis. It will be mistaken for an encephalitis. There will be fever, and it will be mistaken for an encephalitis with the regression of milestones. We will give acyclovir.
Gautry syndrome.
No, glutaric aciduria. Glutaric aciduria. Aicardi-Gouttiere is an interferonopathy, which has got other manifestations also, like hepatosplenomegaly, rash, etc. Here, nothing of that sort occurs. The child has got an encephalitic-like illness, which is treated as encephalitis as AES. Following that, the child loses everything. At that time, we may not realize. Later on, the child presents with movement abnormalities, movement disorder. And then only we recognize, and the consanguinity may or may not be there. Okay, type 1 glutaric aciduria. And what is the other presentation of type 1 glutaric aciduria? Another presentation is slowly evolving, not with a sudden regression, slowly evolving with the development of extrapyramidal manifestations as well as spasticity later on. Okay. Glutaric aciduria is one condition. From my experience in MD pediatrics, I think glutaric aciduria is one condition you have to additionally read a little, especially regarding type 1. And among the other neurodegenerative, the most important we have to read are Niemann-Pick, Gaucher, Niemann-Pick, Tay-Sachs, then NCL, and Fabry also you can read, but not much questions will come. NCL and one more thing. One more thing was there. Tay-Sachs. Did we say Tay-Sachs? Tay-Sachs and Hoff.
Yes.
Okay. So all these Tay-Sachs, Gaucher, Niemann-Pick, then Sandhoff disease, MPS, glycogen storage disorder. These are the things that you need to, as an MD pediatrics PD, you need to read through all the types and have an understanding of how they present. You must have a basic understanding of how they present, what age group they present like that. It will be difficult at first, but if you read again, you will be able to keep it in mind. You can read from Fenichel or directly from your Nelson also. Nelson also gives something, but you can, as a reference, you can use Swayman. Swayman is simple language, easily understandable, but you can take that relevant portion and read only. No need to read the whole book. Even Nelson, I could not read the whole book. Only relevant portions we used to read for case presentation and all that. Okay.
Development
Gross motor. Yes.
Gross motor head control attained by 7 months, rollover by 9 months, sit support by 10 months. Now the baby has no head control. Fine motor, bilateral approach attained by 7 months, unilateral approach by 9 months. Now the baby is not able to reach onto objects. Social milestones, social smile by 5 months, recognized mother by 7 months. Now the baby does not recognize mother or have social smile. Language milestones, alertness to sound by 5 months, moving 7 months, monosyllables by 9 months. Now the baby is allowed to sound with the chanting response. Hearing, chanting response of the hearing sounds, does not turn head to the side sound. Vision, looks at light, fixation is present and follows object.
Okay. One thing. Can we? Just a thing of what is the presentation of Pelizaeus-Merzbacher disease, PMD, as a leukodystrophy? What is the usual presentation? Childhood. It is not in infancy. The usual presentation is in childhood. What does it mimic? What type of CP does it mimic? It may mimic either ataxic CP or spastic ataxic CP, mixed CP. So ataxia is prominent, as well as some spasticity may be there, but not that much spasticity as in case of metachromatic or Krabbe. Okay, so Pelizaeus-Merzbacher disease does not usually typically fit in with this presentation, and it does not have that episodic regression also. It's what is the peculiarity of Pelizaeus-Merzbacher? Why always we tend to miss it unless we take an MRI? Because it exactly looks like a CP with a very slow progression. This progression is very slow, so that it looks like the thing is static. You understand? Okay. Hearing, starting response. Okay. Hearing, vision, looks at light, fixation present. Follow. This was that. Now, what the ability present now you are telling. Looks at light. Yes. Fixation is still present, isn't it? Fixation is present and follows objects. So, okay. So that means even if the white matter involvement we are considering, the white matter of the posterior region is not that involved. Only the anterior region may be involved, especially the motor control and the anterior frontal. Even if we are considering a leukodystrophy, it is not fitting with the adrenal leukotype present. So one thing I would like to take down, which is present in that is you just take down front MRI features. You just write frontal white matter involvement with the genus pairing. frontal white matter involvement with the genus pairing Alexander. Bilateral periventricular white matter involvement initially is Krabbe and MLD. Bilateral periventricular white matter initially is Krabbe and MLD. And posterior parieto-occipital white matter involvement, adrenoleukodystrophy. Then one more thing. Hypomyelination picture with a tigroid appearance. Hypomyelination picture with a tigroid appearance or leopard skin appearance is seen in PMD, Pelizaeus-Merzbacher disease. Fetal brain appearance of the white matter. Fetal brain appearance of the white matter with extensive, that is, there is no myelination, with amyelination, 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 fetal brain appearance of the white matter with amyelination, Canavan disease. Canavan disease is another condition, which is associated with not only the motor aspect, but the vision, hearing, everything is lost. Because the full myelin is involved up to the U fibers. You see, what is other leukodystrophy, which also later involves the U fibers? Krabbe is another thing which also involves the U fibers later on. Alexander can also involve the U fibers of the frontal region later on. But Alexander, the thing is, it usually does not present during childhood, usually presents during adult or adolescent, 10%. And it can be mistaken for multiple sclerosis, etc. also. Okay, fixation present follows objects. Okay, then.
Nutrition and diet history, exclusive breastfeeding till 6 months. Complementary feeding started at 6 months with ragi. Family food diet started by 11 months. 24-hour dietary recall showed an observed calorie of 650 calories against an expected of 1010 calories with a deficit of 460 calories. Protein observed of 18.75 gram against an expected of 9.2 gram with no deficit. Direct breastfeed 2 times.
So dietary intake is less, isn't it? I mean, yes. The mother is trying to give. Is she giving through rice tube? Is there any swallowing difficulty? Only tongue thrust?
No. Only tongue thrust is there. The mother feeds with her hand.
And only. What does she give? What texture? Semi-solid or normal food like idli, dosha, directly or semi-solid, making it?
Not making it semi-solid. She gives it directly only.
And that means the child is able to, in spite of this difficulty, the child's swallowing and chewing function is still intact. I mean, you said like tongue thrust. So you should definitely ask mother whether the child is able to keep it in mouth, chew, then swallow. These are very important.
Yes. The child is able to chew. The child, even when child lies down, child usually assumes a chewing type of movement, even when the child simply lies down.
Oh, okay. Why I am asking is because in neurological cases with the swallowing difficulty like CP, etc., we usually tend to give semi-solid feeds of the consistency, which usually can go down on its own weight when put over a 45-degree slant steel plate. The consistency of the semi-solid that should be given to CP children with oropharyngeal dyskinesia or other neurodegenerative conditions with oropharyngeal dyskinesia is of the consistency such that when it is put into a 45-degree slant steel plate, it should go down in a steady manner with its own weight, without running away too fast and without sticking to the plate. That is a consistency. That is one thing that you have to advise mothers when faced with such children. Only for that I told. Now you can, because why I am asking regarding nutrition, I am trying to see whether there is any failure to thrive?
No failure to thrive there.
Weight is now how much now?
Weight is 10 point. Weight is 10.6.
10.6. Okay. That is
expected is 10.6. The weight is actually 8.9.
So, according to your FTT criteria, is there any FTT? No. Only malnutrition is there.
Malnutrition. The child is having only mild malnutrition, no moderate malnutrition. The weight for length is between -1 and -2 standard deviation. So, sir.
1 minute, 1 minute. I'm muting for 2 minutes.
Sorry.
Tell me 2 neurodegenerative conditions where there is a failure to thrive. 2 neurodegenerative conditions, which is very important, because that is why in those conditions we have to take a correct dietary history, and in spite of the diet being correct, the child still fails to thrive. We need to think of those conditions. One condition is where liver is additionally involved. Another condition is common neurodegenerative. Type 1, I mean type A. Niemann-Pick type A. Niemann-Pick type A and tyrosinemia. See, there may be other conditions also. Lot of variations, conditions are there, but these 2 are very prominent. Tyrosinemia and this Niemann-Pick type A, there is failure to thrive. So that in that aspect, our nutrition history becomes very important. We have to demonstrate to the examiner that we have taken the nutrition history correctly, and we have found out that there is no adequate calorie and protein gap to cause this much of FTT. So this FTT is due to the primary neurological condition only. Okay. Okay, you can please continue. Have you taken food? I mean, you may be hungry. Are you having headache or something? No.
No, sir. No, sir.
Okay.
Diet includes a good amount of cereals, pulses, eggs, green leafy vegetables. Diet lacks fish and meat consumption.
If you are in my room, I mean, if we were discussing in our room, I usually buy food for the PGs. But unfortunately, you are in Kottayam, so I cannot Swiggy. Okay. Okay. That is, vaccination is correct. Then BCS car is present. So everything has been taken. Okay.
Yes.
Okay. Any regression with vaccination? No. No regression. As far as we are concerned, I mean, 1 year, 3 months, the infection caused regression. No, vaccination is not causing any regression. Many of our epileptic encephalopathy children develop epilepsy and regression following this vaccination. But here there is no vaccination associated regression. Okay.
Coming on the family history, the child is born to a
can I ask one question? That is, with the available history and etc. I mean, like there is a global regression is taking place. With the motor involvement is also prominent. Do we where do we localize regression? Gray matter or white matter?
Since the child is having early onset of
no, developmental delay per se, we cannot take as a marker. I mean, because what we find is that there is no seizure. There is no seizure. There is no myoclonus. There is no involuntary movements. Those things, like the regression is affecting both the mental and the motor aspects both are affected. So I think either it may be a mixed regression or it may be a white matter. If we are thinking in terms of gray, white, and mixed, it may be either a mixed type or a white matter. But the point against a pure gray matter is that none of the features of pure gray matter are there, like seizures, myoclonus, dementia only initially presenting. Those are not there. It is a global regression only. Okay.
The child is born to a mother is 26-year-old, and the child is having an elder sibling who is 5-year-old and developmentally normal. No history of any abortions, no history of any stillbirth, infant death, no history of any developmental delays, no history of any congenital anomalies in family. Socioeconomic history: father studied up to +2, He's a mechanic in a workshop. Mother studied up to +2. She's a homemaker. Within family income of 24,000. They belong to a lower middle class according to modified Kupuskami scale. Coming under summary from history. 1 year, 9-month-old baby born out of third-degree consanguineous marriage with no significant family history. Baby born as a preterm and had a stormy neonatal period secondary to prematurity and respiratory distress. The child had a delay in attaining developmental milestones. By 10 months, baby had a
Fever.
fever.
After which one will notice regression of milestones. Currently, okay.
Baby is not having head control, might suffer social smile, not vocalize, but is having startling response to sound.
Okay, with this, we have already have 3 diagnostic from the history. What we should try to formulate is either a single diagnostic hypothesis or a differential diagnosis. We have almost like 4 differential diagnoses. That is, one is we can think of mitochondrial. Second is urea cycle. Third is a leukodystrophy, which has got psychomotor regression like Krabbe. And the fourth is any other inborn error metabolism, not specific. So the 4 differential diagnoses we have. So with that we should direct our head-to-foot examination and other general examination, etc., to any possible causes among these. Like any features suggesting like this, for example, the hair abnormality in Arjuna succeeding. Leukodystrophy usually does not tend to give out any external abnormalities, usually, except for macrocephaly. What are the 2 leukodystrophies where macrocephaly occurs?
Alexander disease and Canavan's disease.
Okay. Then this thing. Okay, leukodystrophy. Okay, so IEM. Okay, so we will proceed to look for any overt abnormalities which may correlate with our DD or any suggest another different diagnosis on examination. Okay.
General examination. Baby is alert, held in mother's lap, gets supported by mother's hand. Occasional spontaneous improvements present. Minimal interaction with the surrounding. No pallor, distress, cyanosis, clubbing, lymphadenopathy or edema.
Okay.
Vital signs: pulse rate of 96 per minute, regular rhythm, normal volume, character. Pulses
If for a neurodegeneration child, pallor and hepatosplenomegaly are there, what are the differential diagnoses? Neurodegeneration, pallor and hepatosplenomegaly. Not for this child, another child.
If hepatosplenomegaly is present, we have to consider
pallor and hepatosplenomegaly, 2 DDs.
Fabry's disease.
No, before that, Gaucher and Niemann-Pick. Bone marrow involvement. Okay. What is that cell in the bone marrow of Niemann-Pick called as? That is typical staining. Large foamy cell, multinucleated or usually sea blue histiocytes. We study in our pathology medal exam and all that. Sea blue histiocytes. So there is what is the look of that abnormal, that is Gaucher accumulating cell in the marrow? Sandpaper.
That is a tissue paper.
Tissue paper. Yes, very good. Tissue paper appearance. Okay. Okay, my baby is alert, held in mother's lap, supported by mother's hand, occasional spontaneous limb movements present, minimal interaction with surroundings, and no pallor, sinus clubbing, lymph. This is what makes me suspicious, that in addition to, because the limb movements are very low, isn't it? From your history, even now, is the child lifting the limb against gravity? No. Limb movements. Is the child obtended? No. Drowsy? No. Child is
no.
Oh, that means child sensory is normal. The child, if willing, can move around the limbs. Okay. But limbs being, look at the child. Child is lying like a hypotonic child, even though hypertonia is there. So this much of weakness, etc. I am also having a suspicion whether there is any additional muscle involvement. What is a condition where encephalopathy with myopathy will occur? In our differential not myelopathy, encephalomyopathy. That is MELAS. Mitochondrial encephalomyopathy with lactic acidose and stroke syndrome. So that can also present with, and MELAS can also present with this type of picture. A delay followed by regression with a minor infection and leading to a very weak picture where both the encephalon as well as the muscle is affected. But we will have lactate, etc. on investigation during the acute phase. What is the peculiarity of MELAS infarct when we compare radiologically MELAS, infarct of MELAS? What is that? Some peculiarities are there for the infarct of MELAS when compared to the usual infarct of artery blockade and MCA infarct, etc. What are the two or three differences between for example, a child with MELAS is there, same age, another child with MCA branch occlusion is there. Both are having, a stroke. One is a mitochondrial stroke, other is an arterial stroke. Vengi, what are the, we should not tire Varun. What are the differences? What do you feel like? MELAS, the infarct of MELAS has got certain peculiarities that you might have studied during your MBBS days, etc. MELAS is a peculiar condition. We often tend to have interest in that. That is
loss, like no pembura, the ischemic.
No edema is there. No surrounding edema is there. And it is almost like a cut cake. You cut a cake, but don't take out the piece. How that is, along with the whole cake, it is integrating with the whole cake. That will be the type of infarct. And another thing is it does not obey the vascular territory. No surrounding edema. No edema, does not obey the vascular territory, and it is mostly posteriorly located, can be seen anteriorly also, and it has got a sort of cut cake appearance where it will be maybe like a wedge, but it will be remaining without producing any disturbance in the nearby brain. No compression effect, nothing. So you remember these points. Okay. No pallor icterus. Icterus associated with an infant with neuroregression, icterus, hepatic involvement. What is one of the differential diagnosis? Tyrosinemia. GM1 gangliosidosis. Okay. Lymphedema is in which condition? Lymphedema of the that will come when we come to the head to foot examination. Will come. Okay. Head to foot what is the relevance of head to foot examination in pediatrics when because we don't have it in adult? What is the relevance of that head to foot examination? Why there is a new thing in addition to the general examination? It's a HFE also. What is the relevance? Two things.
The head and the dysmorphism may.
One is that we will encounter a lot of genetic conditions in childhood. Second, so we had to take out everything like the dermatoglyphics, the nails, everything, polydactyly, syndactyly. Second thing, we have tuft of hair, lipoma, everything we had to look. So second thing is that the head to foot examination is tailored according to the condition. Suppose you are getting a serious condition, you look mainly in the pectus excavatum, webbing of neck, your attitude will be different. The attitude for HFE is different for different condition. If it is a neuro condition, we will look for the neuro-related things like spinal abnormality, kyphoscoliosis, dysostiosis, those things. So you remember one thing, Vengu and Varun, my brother, Dr. Sulfikar, told me one tip to prepare for the MD exam. That is, I was actually a directionless, what to study, what book to read, etc. I was presenting cases, but not able to focus what to do. So he told me, you take out you ask your seniors regarding what are the cases usually kept in exam. And you prepare a notebook logbook or notebook where you write down one case. For example, Down syndrome with VSC and long bronchopneumonia. Okay, so you write down what to ask, what to look, nowadays it has become easier with the Scots pediatrics, etc. But at that time there was nothing like that in our PG 2002. I will prepare Down syndrome, then I will prepare VSD, PDA separately, then other things like short cases. So we will prepare and keep so that we know our deficiencies, what we don't know. So our deficiencies we correct immediately. For example, then I understand that failure to thrive criteria, I don't know. So I know only PM. So I will immediately look up. And on the opposite side of the notebook, we will have clustered information. Those questions that examiners ask where we had to give 3 or 4 causes immediately. So that is what to ask, what to look, and what to how to investigate, and what are the possible questions from that. So that if we prepare in advance, in the exam, we are not stunned. We can quickly answer. This is one technique my brother taught me during my pediatric days. His posting was the toughest posting. It's very punctual. That is the problem. Okay, then continue. 1 minute. You are going when you go to the HF, you say. Now we are going to the vital signs. Vital signs. Pulse rate 96 per minute, regular volume, normal volume, peripheral pulses bilaterally, blood pressure 88, 58. Okay. Respiratory rate 24 per minute, normal temperature. Okay. Head to foot examination. Head size appears normal. Left hospital plagiocephaly. Plagiocephaly may be because of the lying on one side. Now reading of switches, AF is closed, hair is normal texture and color. So our possibility of arsenic is a little less. My eyes, no corneal clouding. So no cataract, no nystagmus. Regarding nystagmus is a peculiarity of two common neurodegenerative disorders. Can you tell two common neurodegeneration that we need to definitely read the types and all that? Nystagmus. That is a neurodegeneration, correct? But it is actually not coming under the correct that Niemann-Pick, Gaucher, those type of storage. It is a different type of mutation. The thing is, Niemann-Pick and Gaucher, we can have ocular movement abnormalities. What is a typical ocular movement abnormality in Niemann-Pick? Eye movement abnormality. We had one patient where we suspected both the Gaucher and Niemann-Pick. When we settled for Niemann-Pick, because that patient was having only vertical supranuclear gaze palsy. Vertical supranuclear gaze palsy, while in Gaucher, there can be horizontal gaze palsy as well as plus or minus vertical supranuclear gaze palsy. But finally, the ensign came as Niemann-Pick positive on testing. So eye movement abnormalities can occur on leukodystrophy. What is that leukodystrophy? Rowing, correct. Pernicious mesh disease, rowing movements of the eye, pendular nystagmus, etc. can occur. What is the relevance of pendular nystagmus? Just asking only. Pendular nystagmus in case of a delayed child or a regressing child.
Cerebellar fibrosis can also be affected.
Pendular nystagmus usually indicates a decreased vision. Afferent, that is vision, decreased vision. It's one of the indicators of decreased vision. Like that congenital blindness or losing vision early, like in NCL, or like that it is also one of the co-indicators along with the absent menace reflex and absence of perception of light, etc. It is one of the co-indicators of decreased vision. Okay, you can continue.
Ear and nose appears normal. Oral cavity open with the saliva is present. Skin normal, no dermatitis or angiokeratoma. Chest no deformity. Abdomen mild distension, no umbilical hernia. External genitalia female type normal. Spine scoliosis with the left sided convexity. Limbs short digits. Skin no hyperpigmentation or neurocutaneous markers. Coming into anthropometry, weight of 8.9 kg against an expect of 10.6 kg between 0 and -2 standard deviation. Length of 80 cm against an expect of 83 cm between 0 and -2 standard deviation. Head circumference of 44.5 cm against an expect of 46.5 cm between -1 and -2 standard deviation. Weight for length between -1 and -2 standard deviation. Mid upper arm circumference 13.4 cm. Complete head lag is present. Head sitting back is curved. Vertical suspension. Lower limbs are extended at knees. No scissoring. Ventral suspension. Head is held below the plane of body. prone person not able to lift the chin. The
1
hands
minute.
are open.
1 minute. 1 minute. One or two questions I prepared for it. Like, you know, this you know that after in the head to foot examination, I wanted 1 or 2 questions. That is, with doll-like phenotype. That is, Hurler phenotype and doll-like phenotype in neurodegeneration. So doll-like phenotype is seen in which conditions? Wengi is my only help because no other PGs are there. Last time also he was the only solace. He's always present in these presentations.
So, like Tejas, Gotches, like
No, Selvager is correct. Mengi also. Mengi is kingy hair, Mengi is kingy hair. That also has got a doll-like look in the face. And one more condition, hypoglycemia, that Von Girky, glycan storage. Even though it's not a neurodegeneration per se, but that also has got this doll-like phenotype. The Hurler phenotype is usually seen in which are conditions in addition to MBS?
ICL disease.
Yes. Anything else closely related to mucopolysaccharidosis? Mucolipidosis. Then anything else? The oligosaccharidosis. Fucosidosis, mannosidosis. Then multiple sulfatase deficiency. All these have Hurler phenotype. And also one more thing, GM1, we forgot. GM1 gangliosidosis also has got Hurler phenotype. Okay. Now, one question. One persistent large Mongolian spot. You are noticing a large Mongolian spot in the back of the child. A large Mongolian so it is persistent also. So what are the possibilities? Neurodegeneration.
It can be seen in Krabbe's MLD.
MBS, it is correct. MBS and GM1 gangliosidosis. Leukodystrophies usually do not have any telltale signs outside, except for that macrocephaly. It's a gray. Always remember, it's the gray matter things usually who tend to have outside problem. Gray matter. That is GM1 gangliosidosis, MPS, and Niemann-Pick. So and also persistent large Mongolian spot is also seen in another group of conditions. What are they? Neurophacomatosis. Neurophacomatosis, like neurofibromatosis, tuberous sclerosis, etc. But as far as we are concerned, in this case, relevant to this case is GM1, MPS, and Niemann-Pick. So corneal opacity. What about corneal opacity? In what all conditions? Neurodegeneration.
Hurler disease is usually seen.
Yes. That is in MPS, in any other, and also related disorders, mannosidosis and mucolipidosis.
Yes.
So corneal opacity can be seen in MPS, mannosidosis, and mucolipidosis. Okay. Then one more difference. Can I ask one difference? That is, if you have vision problem in both gray matter and the white matter neurodegeneration. Okay, you are looking at the fundus. You are seeing a primary optic atrophy. What localization will you give? Gray or white?
Sir, I could hear there was
that is, you are looking at the fundus of a child with neurodegeneration. You are getting primary optic atrophy. So what does it point to? Which type of neurodegeneration?
White matter.
Very good. Correct. Because optic nerve is a white matter tract. Okay. Then the thing is, you are getting a consecutive optic atrophy. Consecutive optic atrophy on looking at the fundus with a brownish yellow hue of the fundus. NCL. You told correctly. NCL, neuron ceroid lipofusion, because it is indicative of a gray matter, especially neuronal ceroid. That is consecutive optic atrophy with the optic disc appearing a pale yellow and a brownish yellow hue to the retina.
Sir, may change my headset is having low charge now.
What?
May change my headset.
Oh, okay. Hello, hello, hello.
Hello, sir. Sir, can you hear me?
Yes, yes, I can hear you.
Yes, sir.
So I was asking consecutive optic atrophy. You are seeing in when you look at the fundus. What does it point to? What type of neurodegeneration?
White matter diseases. White matter diseases, sir.
No, it is gray matter. It is mainly seen in NCL, neuronal ceroid lipofuscinosis. And also, you remember one more thing: this retinitis pigmentosa. Retinitis pigmentosa. That is also a feature of gray matter neurodegeneration. Can you tell one or two conditions where it is seen? In our condition, this child, we can look for that because we are suspecting mitochondrial disorder.
Yes.
In mitochondrial disorders, you can get it. You can get it in neuronal ceroid lipofuscinosis, NCL. You can get it cell vector, peroxisomal disorders, and also in NBA, that is neuronal brain iron accumulation disease. That is your pantothenate kinase deficiency. That was previously called as Haller-Warden spats. Okay, don't worry.
Sir, one problem with my headset.
No issues. Now the thing is, our discussion is almost finished. Our discussion is almost finished. So, like, I will do one thing. I have prepared a on chart for you for quick analysis.
Sir, it's all right now. It's all right. I'm not using headset. I'm using directly from the lab.
Okay, that you are audible. You are audible.
Yes, sir. Yes, sir.
So retinitis pigmentosa, remember, it is seen in organelle disease like mitochondrial, cell vector, neuronal ceroid lipofuscinosis, and PCAN. PCAN is pantothenate kinase associated. That was previously called by one nasty doctor name, Haller-Warden spats. That okay. Now, what about cherry red spot? This is another thing you should look.
Cherry red spot is
seen?
It's in a Tay-Sachs disease. It can also be seen in the GM1 gangliosidosis, Sandhoff disease, Niemann-Pick disease.
Correct. And also sialidosis.
Also.
Okay. Optic atrophy is usually primary is seen in our leukodystrophy. Okay. Then I already told you regarding nystagmus, Gaucher, Niemann-Pick, Pelizaeus-Merzbacher disease, ataxia, telangiectasia, and one more condition is Kearns-Sayre syndrome. This where nystagmus, Kearns-Sayre syndrome. Then okay. So can you tell me because we have possible spasticity in this child, can you tell me 2 or 3 or 4 conditions, neurodegenerative conditions with the spasticity being prominent other than leukodystrophy?
Other than leukodystrophy,
spasticity is a prominent feature.
In Tay-Sachs disease, after the initial hypotonic phase, the child may have.
Okay, that is correct. Then too common just like Tay-Sachs, that same pocket. I mean, 2 common disorders. We will not think of them immediately because we have a certain idea of them, but their types, type 3, the later types will manifest with spasticity, not the infant. Gaucher type 3. Gaucher type 3 and Niemann-Pick type C. So now another condition, a degenerative condition where spasticity is there is HSP, but that is not within our purview. It is not usually seen in our setup, and it's in a higher age group. HSP is hereditary spastic paraparesis, but that is not considered as along with this condition, even though it is a degenerative condition. Then can you tell 4 conditions where there is degenerative disorder with the extrapyramidal symptoms.
Degenerative disorder with the
Extrapyramidal.
Rett syndrome may show.
But Rett is not a typical. You should not tell Rett first. You should always tell glutaric aciduria first. Glutaric aciduria, then you can immediately tell PCAN, because you know Haller-Warden's patch definitely involves the basal ganglia. Then you can tell Lesch-Nyhan. Then you can tell these are the always in medicine, common things are common, uncommon things are uncommon. That is what my professor Dr. Joy Philip taught me. He expired a few years back. So that is common things we should tell, like glutaric aciduria, Lesch-Nyhan, this PCAN. Then comes the other things like juvenile GM2. You know, juvenile GM2 gangliosidosis. Then neuroacanthocytosis. And one more condition which is usually seen in adolescent, not in this age group. Adolescent is SCA type 3. SCA type 3. That is spinocerebellar ataxia type 3. It is called as other name is Mercado-Joseph disease. So then, okay, what are the leukodystrophies which are associated with neuropathy?
Metachromatic leukodystrophy and adrenoleukodystrophy can be associated with the peripheral neuropathy.
What about Krabbe and PMD? They also have. Krabbe definitely has. PMD also may have associated neuropathic involvement, NCV, abnormality, etc. So we will do one thing. We will quickly finish because I mean time is lot. The other people may be tired. So you continue. I have prepared this. I will show you. I mean, I will send to Thomas. You can get it from him. How to? I mean, because you know the analysis of white matter leukodystrophy is very easy. Because you need to look at the head size. You take an MRI. Suddenly, you can make the diagnosis. And you also need to do a nerve conduction study. But gray matter neurodegeneration approach is slightly different. But the main checkpoints that we use, you can write it down. One is hepatosplenomegaly. Second is you look for dysmorphism. Third is you look for seizure. And fourth you look for cherry red spot. These are the four things, checkpoints for differentiating between the to the approach for the gray matter neurodegeneration that I have prepared for you. That I will send you via Thomas. That you can use it as a quick reference before the exam. Okay, you continue. Yes, I will not be interrupting too much now. The time is, I think, already 10. So I am not tired because I can go on and go on. Like, you know, Captain America says, I can go on like this. Says to that other guy who is that friend, Bucky, while he's getting beaten up by that gangster, he's saying, I can go on like this forever. So that is not, but the other people are tired. That we should understand. So you can go quickly. I will not interrupt you. So we did not get, except for the scoliosis, we did not get any clue for the neurodegeneration from the head to foot examination.
Then a plagiocephaly was also present.
Plagiocephaly, we cannot give too much importance also. Yes. And also the malnutrition, I mean, head circumference is not having any, there is no definite microcephaly. No definite microcephaly. Okay.
It's between -1 and -2 standard deviation.
Okay, you can continue.
Development assessment, gross motor, pull to sit, complete head lag is present, back is curved, lower limbs extended at knees, no scissoring, head is held below the plane of body, not able to lift the chin.
Head is held below the plane of the body. Okay, below the plane of the body. When does that is, you mean it's a RA position, ragdoll?
Yes, it's almost a RAM position, sir.
Okay, ragdoll is due to what problem? What is the problem in ragdoll? It is weakness. It indicates very much high weakness. And another thing, prone not able to even lift the chin. That indicates that the motor development has regressed that much. Yes. Even it has regressed to less than 45 days, I think.
Yes.
and pull to sit is complete head lag. Now, regarding this, I will tell you one thing. Next time you try to take a CP patient, we will discuss 4 situations which are important both for the CP and floppy, where we can quickly distinguish a normal infant of 4 months, hypotonic phase of spastic CP, atonic CP, and SMA. How to differentiate with using the 360-degree flip maneuver. That I will tell you next time. You can write it in a column next time. Next, any January, etc., any month coming, we will take a CP, because CP is very important for your exam. Your exam is when?
January 24th.
January 24th. Okay. Okay. Before that, we had to take. Maybe when you get time, when you get a slot, you just ask. I can even, not as part of IAP, I can even take as a class for you people if there is no slot in the IAP. Okay. CP I am very much fond of. A lot of things are there for question answer also. Okay, that we will take later on. Before your exam, we have to take. We can arrange as a group 5 people only. Vengi, yourself, Gobi, and Divya, and we can take as a simple class before the exam, because there is no time for an IAP posting, because we have to rotate. IAP has to rotate. Okay. Okay, then you go on.
Hands open. No voluntary grasp is present. Looks at objects at midline and follows up to 90 degree. Does not recognize mother's face. Startle response on hearing sound is present. No vocalization. The baby is having complete head lag. No scissoring of gait.
In spite of what you said, like increased tone in the legs, the legs are not that much having an extensor posturing, isn't it? Legs are as though they are very weak and flail, appearing flail. When you examine the child, did you find adductor spasm or hamstring spasm?
Adductor spasm is present. The mother also does not complain of any difficulty in wearing diaper.
No adductor spasm is present, and you did not find any increased spasticity also.
I got a spasticity, increased spasticity, but it was varying actually.
Varying. Oh, that means varying tone means that there may be involvement of basal ganglia, but we cannot be sure because we don't have any movement disorder. And the child is very weak also. A very weak child without any movement disorder usually indicates a affection of the white matter or gray matter or both, rather than a basal ganglia. Because, in dyskinetic CP, there is no weakness per se, only execution difficulty. There is no weakness, but here the child is very weak. So that indicates that the pyramidal tract is definitely involved, but not only the pyramidal tract, the gray matter is also involved. It may be a mixed type of CP where there may be IEM or a mitochondrial, because mitochondrial can involve both gray plus white. Rather than because leukodystrophy, we should have got at least, extensor posture while vertical suspension. Then suppose this child is 4 years old and then you are not getting hypertonia, you can explain by, 3-year-old and you are not getting, you can explain by saying that, sir, peripheral neuropathy has additionally appeared so that the tone is low now. Initially it was high. See, Krabbe, leukodystrophy, metachromic, etc. Later on the tone decreases, the spasticity decreases because peripheral neuropathy additionally supervenes. So it becomes LM and hypotonia. So that in that way we can explain. Another way we can explain is we can say whatever the pathology is there is affecting not only the brain, it is affecting the nerves and muscle also, the neuromuscular unit also. That is one way of explaining. Because I expected extensor from your history, not getting the extensor posturing in vertical suspension. Okay. And the position is ragdoll only. Ragdoll position. Okay.
Yes. Coming on to the central nervous system examination. Higher mental function, baby is alert.
One more clarification. Is this 360-degree flip maneuver? Among that, the prone position, the prone position alone is the indicator of the development. All the other 3 things like pull to, I understand that pull to sit, head lag, it should not be there for a 4-month-old child. That I understand, it's part of development. But when we are examining a pathological child, this pull to sit, head lag, and prone position are for the development, while the ventral suspension and the vertical suspension are especially for knowing the tone, weakness, and categorizing what type of CP or CP mimic it is. Okay, so that tone assessment Ventral suspension and vertical suspension are very important. But for developmental assessment, prone position and pull to sit from supine are important. Okay. Now coming to the next slide.
The central nervous system examination, higher mental function, baby is alert, minimal interaction with the surrounding, no vocalization is present.
Okay.
Then cranial nerve examination, olfactory nerve is not tested, ophthalmic nerve, visual acuity fixates and follows objects to 90-degree fundus. In bilateral eyes, a cherry red spot was present.
In both eyes. Okay.
Both eyes.
Okay. So we are very curious about hepatosplenomegaly now. Okay. Whether any hepatosplenomegaly is present or not, that we are curious.
Yes.
Okay.
Oculomotor nerve, trochlear nerve, abducens nerve, no doses.
If hepatosplenomegaly is present and the cherry red spot is present without any Hurler phenotype, what could be one possibility?
Sandhoff disease.
Yes, that is Sandhoff. Very good. Sandhoff is a possibility. Sandhoff and also sialidosis. Also, we can consider. Sialidosis also we can consider. Okay. But sialidosis will have one problem. The dysmorphism will be there. The child is not dysmorphic.
Yes.
Okay. But we are very curious regarding where hepatosplenomegaly. This case we are curious. Okay.
Oculomotor nerve, trochlear and abducens nerve, no ptosis, squint or nystagmus is present. Pupil, direct and indirect reflex are present. Trigeminal nerve, no deviation of jaw on opening of mouth, corneal reflex, conjunctival reflex and jaw jerk present. Facial nerve, blinking of eyes present, nasolabial fold bilaterally prominent, no deviation of angle of mouth, vestibulocochlear nerve, cochlear part startling response to sound is present, no nystagmus, glossopharyngeal and vagus nerve, position of uvula central, movement of palate symmetrical and equal, gag reflex and palatal reflex were present but not exaggerated, accessory nerve was not tested. Hypoglossal nerve, no deviation of tongue on protrusion, no tongue fasciculations were present. Coming to motor system examination, bulk of muscles, no visible wasting or hypertrophy, no flappiness on palpation. The measurement showed the arm, forearm, thigh, and leg had similar values, equal values both bilaterally. Tone assessment, the upper limb and lower limb had increased tone with the spasticity present.
Okay, that you should actually confirm with the Thomas also, because the baby was not having that posturing, etc. That is why you can confirm with the Thomas also. Okay. But you feel that it is tone is increased. But you said that you did not get adductor catch or adductor spasm, nothing was there. But when you were doing passive movements, you felt like some stiffness was there.
Yes,
okay. What is the earliest muscle to have spasticity in the lower limb? Earliest adductor. Earliest. Adductor is the earliest to have spasticity. But another thing that is applicable mainly in CP. Then another thing is upper limb pronatory zone that will have earliest spasticity. But that is not applicable to neurodegeneration. Neurodegeneration can have varying features. Okay, adductor angle is only 70. Okay. Yes. Popliteal angle is 110. So definitely the angles are also giving features of increased tone. Okay.
The occipluction angle is increased. The scarf line does not reach the midline.
Midline. Okay. So it is a spasticity is definitely there. Okay.
Yes. Power, upper limb and lower limb.
Very low power. 2/5.
Low power of 2/5 is present on right side and left side with the minimal spontaneous movement of limbs. Reflexes, superficial reflexes, conjunctival and abdominal reflex is present. Plantar reflex is bilaterally extensor.
Okay.
Deep tendon reflexes, jaw jerk present, biceps, supinator jerk, tricep jerk, and knee jerk exaggerated, ankle jerk exaggerated with the clonus on both sides. It shows exaggerated. Knee jerk. Angle jerk.
So clonus is as a well-sustained clonus is also obtained.
Yes.
Okay.
It is not very sustained. It's a ill-sustained clonus was obtained.
But no problem. Anyway, you are saying that the reflex are increased, exaggerated. Okay.
Now that left and clonus was present.
Okay, analysis. You are quickly getting, quickly getting without any difficulty.
Yes.
Okay, okay. Then, okay. Exaggerated, usually the range also should be more, but we don't know whether any contraction is there. It can sometimes limit. Okay. But anyway, you are getting clonus quickly.
Yes.
That means there is an element of pyramidal which may be superadded by other things. Cerebellar involvement may lighten its effect. Any additional cerebellar involvement can lighten the effect of the pyramidal involvement. Okay.
The upper limb deep tendon reflexes, which also showed it. Brisk reflexes.
Okay. It is brisk only. Reflex are brisk. Okay. So I think from the pictures that you are showing, I think it's mainly on the brisk side rather than exaggerated, I think. But even that is relevant in such a weak child. Okay.
Primitive reflexes, sucking and rooting reflex are present. No glabellar tap and palmomental reflex present. No palmomental reflex.
Okay. Sensory system we cannot assess. Cerebellar signs in this weak child we need not assess.
No
Except for
nystagmus.
nystagmus, other things we cannot assess in a weak child, because only if the power is grade 4, it is better to assess the cerebellar. No excess setting. Okay. So we have finally before summarizing, we need to know the, that hepatosplenomegaly.
Hepatosplenomegaly. Gastrointestinal system. The lower part of the liver was a palpable 2 centimeter below right coastal margin.
Oh, there is no hepatosplenomegaly.
No hepatosplenomegaly was present.
Okay, then our differential diagnosis becomes like Tay-Sachs is also comes as one possibility. That is a late onset, not the infant age, but the juvenile Tay-Sachs is one possibility, because you said regarding hyper alertness to sound.
Yes.
Then
also present.
No hepatosplenomegaly. That is why I brought in juvenile Tay-Sachs. Then another possibility is you can think of sialidosis variant, because sialidosis can have present without hepatosplenomegaly, and it can also present with the hepatosplenomegaly also. There are two types. So another differential diagnosis coming is, but we don't have any megalencephaly, isn't it? Head size is normal.
Normal.
No, my head size normal with the cherry red spot and resembling Tay-Sachs, etc. One diagnostic possibility is sialidosis. Sialidosis, but the thing is that sialidosis, many patients show myoclonus. Here, myoclonus is not there. Then we can also think of the GM1 is out of the picture, because we don't get any skin abnormality, lymphedema, nothing is there. And Gaucher is also out of the picture. It is not matching with the Gaucher. And Niemann-Pick, what about Niemann-Pick? Niemann-Pick type, first is 3 months, second is between 2 to 5 years. That when we think of Niemann-Pick also, we need to have hepatosplenomegaly. Usually Niemann-Pick, except for the initial type, has got prominent hepatosplenomegaly. So that is also out of the picture. I think it's more fits with the juvenile Tay-Sachs bar sialidosis. Out of that, we can finalize it as more likely to be sialidosis, but we need to read more regarding the types of sialidosis, which one matches this. Okay, and because other things like other conditions like Menge, etc., everything is out. That is less likely, because hepatosplenomegaly is a very important finding. Since hepatosplenomegaly is not there, we can consider, but the problem is that there is no cherry red spot in these conditions. In NCL, etc., we tend to get retinitis pigmentosa and other things also. So that is totally out of the picture. Fundus we have seen already. Fundus any find? Were you able to see fundus? That is where cherry red spot comes. What about the other things like any red RP? Additional finding, nothing is there.
No, nothing else was there.
Okay. On the whole, our final diagnosis would be like either because we consider in the history, we considered mitochondrial, urea cycle, leukodystrophy, etc. But when cherry rod spot came in, the different diagnosis becomes totally different because that is not seen in leukodystrophy. So leukodystrophy is out of the picture. And the mitochondrial do not usually show cherry red spot, which is one finding which takes away the diagnosis to another realm. So we have to think about the other neurodegenerations, like where cherry red spot is seen. You are sure, isn't it? Cherry red spot, you are sure that Thomas has also, I mean, confirmed by consultant also.
Yes.
Okay. Oh, okay. Then okay, you can summarize. 1 year 9 months that
1 year
history I
9 month
know.
old baby
History I
girl
know.
born out of
Okay.
a third-degree
Global
consecutive.
regression. Global regression, and on examination, normal head size, spasticity in all 4 limbs, exaggerate deep tendon reflexes with angle clonus, extensor plantar, starter response, visual hearing impairment, cherry red spot present, no organomegaly. That is very significant. Okay, so I think we can satisfy ourselves with Tay-Sachs disease or sialidosis. Okay, Sandhoff. Okay, Sandhoff we can consider, but Sandhoff usually has got organomegaly, isn't it? So you cut off the Sandhoff. We can consider Tay-Sachs. DM1, the problem is that other features of DM1 like Hurler phenotype and lymphedema, etc. are not there. The cutaneous manifestations are not there. So we can cut off DM1. Niemann-Pick type A usually presents at the age of 3 months. So type A is less likely. Type B, what about type B? Type A is mainly neurovisceral. Type B is more of visceral or neuro?
More of visceral.
More of visceral rather than neuro. And it also presents at a higher age group, a little more higher age group. I think if I remember correctly, between Niemann-Pick type B after 1 year, I think. After 1 year. That I need to check. 1 minute. Yes. Type B. I had prepared a small note for that. That also I will send to you. Type B Niemann-Pick 6 months to 3 years. More visceral, less neurological features. So that is one point differentiating that from the. And type C is 2 to 10 years with the neurological more than visceral, with the vertical supranuclear. That is actually that we see often in the childhood. So that is not fitting with the Niemann-Pick. And this condition is not fitting with the Gaucher also. So I think Tay-Sachs is first possibility. We can take away the Sandhoff, DM1 and Niemann-Pick. Then Gaucher type 2, I will tell you that is actually a slightly coming in. But the thing is, a typical clinical picture I will tell you, because after the initial regression, the child within the first 1.5 years itself, the child goes into an opistotonic position with a tetanus-like presentation. Opistotonus with the tetanus like exactly looks like tetanus because the child has got a retrocolis, the opistotonus, the child has got trismus, the child cannot be fed through the mouth, the child riles tube is compulsory, and the child is sometimes in pain also because of the severe muscle spasm and all that. So the Gaucher type 2 is out. What about Gaucher type 3? Gaucher type 3 is a slow presentation. It is occurring in childhood with the psychomotor regression, but mainly initially spasticity and ataxia, along with the hepatosplenomegaly. So Gaucher type 3 is a neurovisceral form, where there is a spastic ataxic gait, fall, etc., followed by hepatosplenomegaly, etc. So that is, Gaucher type 3 is not matching here. Gaucher type 1 cannot be put because it is gross hepatosplenomegaly. And Gaucher type 2, type 2 is neuronal form, but the presentation is with the opistotonus and the tetanus-like presentation. So there is one point against, but still you do one thing, you keep the Tay-Sachs and the Gaucher type 2 because they can present during this age group. Okay, we'll keep it. One more differential diagnosis we need to keep is our sialidosis. Please read regarding the type of sialidosis because I did not read regarding that. I only know sialidosis has got cherry red spot, myoclonus, and possibly seizures also, but I did not read the subtypes of sialidosis. So you read the subtypes of whether anything matches with this picture. Okay, but definitely even if cherry red spot was not there, I would have definitely considered the organal diseases in more preference to the neurodegeneration because of the sudden deterioration with illness. Okay. Still, I am suspicious, but because cherry red spot is there, I am altering the diagnosis. Okay, because Chandra madam always says, my professor, So motor signs are the hard signs, and the sensory signs are the soft signs, and odd signs, odd signs should always make you rethink your diagnosis. There is no problem. നമ്മുടെ മൊബൈലിന് 3 കൊമ്പെന്ന് പറഞ്ഞിരിക്കേണ്ട ആവശ്യമേ ഇല്ല. നമുക്കൊരു ഓഡ് ഫൈൻഡിങ് കിട്ടിയാൽ നമ്മൾ ഡയഗ്നോസിസ് മാറ്റണം, ഫ്ലെക്സിബിൾ ആയിരിക്കണം ഡയഗ്നോസിസിൽ. We thought of the possible history. With the history, we had 3 DDs, but unfortunately, on examination, we became wiser because we got a new very important finding, very characteristic finding, which is seen only in certain conditions. And in the certain conditions, whatever condition having hepatosplenomegaly is taken out, we have only Tay-Sachs and Gaucher type 2 and sialodosis. And sialodosis has got a form with hepatosplenomegaly. It also has a form more having neurological involvement also, so that we can read. Okay. Then I also thought of other things like muco, that is fucosyl, manosyl, etc. But the problem is hepatosplenomegaly is a prominent feature, so we cannot think of that. Okay, we will stop at this thing, sir. It was a very good discussion. I will do one thing. I will send you for your personal keeping only. You need not give to as a final year your personal keeping. I will send you that for the final years only, the one neurodegeneration presentation prepared by me. That is actually very good for before the exam. You can just go through it. You'll get some additional ideas from that. And this picture also I will send. The algorithm for approaching gray matter I will send. White matter I will send the presentation to Thomas and you. Okay. Thank you very much. Thank you everybody. Whoever is present, thank you for the person listening. It was a.
Thank you, sir. Thank you.
Okay. Thomas ഉണ്ട് എപ്പോഴും. ഞാൻ
തോമസ് ഉണ്ട് സാറേ. താങ്ക് യു.
താങ്ക് യു മാഡം. താങ്ക് യു മാഡം. ഇന്ന് എനിക്ക് ഭയങ്കര ഒരു ഓണറാണ്. നമ്മളൊക്കെ കാലിൽ തൊഴേണ്ട ആൾക്കാരൊക്കെ നമ്മളിത് പ്രസന്റേഷൻ കേട്ട് ഇരുന്നല്ലോ എന്നുള്ളതാണ്. താങ്ക് യു മാഡം. Thank you everybody.
Thank you, sir. Thank you, sir. Good night.
തോമസ്, ഞാനേ സമയമില്ലെങ്കിൽ അവർക്ക് സമയം ഒട്ടുമില്ല, ജനുവരിയിൽ എക്സാം ആണ്. അപ്പൊ ഇൻ കേസ് ക്ലാസ് എടുക്കാൻ പറ്റിയില്ലെങ്കിൽ ഞാൻ പെഡിക്കോണിന് വേണ്ടി പ്രിപ്പയർ ചെയ്ത ഒരു പ്രസന്റേഷൻ ഉണ്ട്. അതിൽ കംപ്ലീറ്റ് ഡീറ്റെയിൽസ് ഉണ്ട് CP-യിൽ. അതെങ്ങനെയാന്ന് വെച്ചാൽ ഞാൻ എന്റെ MD സമയത്ത് നോക്കിയപ്പോൾ CP ഒരു ബുക്കിലും നല്ലപോലെ ഇല്ല. അപ്പം ഒരുപാട് ബുക്കുകൾ, ജേണൽ എല്ലാം തപ്പിപ്പിടിച്ച് അതിൽ നിന്നെല്ലാം കൂടെ എല്ലാത്തിനും കൂടെ ഒരുമിച്ചാക്കി കൺഫ്യൂഷൻ ഇല്ലാത്ത രീതിയിൽ, അതായത് CP-യുടെ കോൺസെപ്റ്റ്. അപ്പം നമുക്ക് ഇവർക്ക് എക്സാം പോണതിന് മുമ്പ് പറ്റുമെങ്കിൽ എടുക്കാം, അല്ലെങ്കിൽ ഞാൻ അത് അയച്ചു തരാം. അത് അവർ വായിച്ചാൽ അവർക്ക് CP-ക്ക് നന്നായിട്ട് ആൻസർ ചെയ്യാൻ പറ്റും. എല്ലാ ആസ്പെക്ട്സും. ഓക്കെ ശരി.
താങ്ക് യു, സർ.
ഓക്കെ സർ.
താങ്ക് യു
മാഡം.
താങ്ക് യു. നൈറ്റ്.
ഗുഡ് നൈറ്റ്.
വരുൺ നന്നായിട്ട് ചെയ്തു കേട്ടോ.